From Microbe TV, this is Infectious Disease Puscast, episode 80, recorded on Wednesday, May 7th, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. How are you today, Daniel?
You know, I had an interesting last few days. I don't know if you ever get feedback on any of the papers we discussed, but got a little feedback on anti-social media.
Okay.
The authors didn't really feel like my interpretation was in line with theirs, and so
Got it.
very, very interesting. I've decided that's what I'm now calling it: anti-social media.
Well, I don't have any new updates. I'm finishing up a little block of service. I was back at Children's this week, so it was fun to hang out on the other side. Switch things up a bit.
Yeah, I'm in my block, one of my blocks at Columbia. This is like I'm doing an extra block. Yeah, they're very smart. They sent me like the email with like, oh, Dan, someone has a conflict, but the medical students and residents love you so much. Would you work extra? I was like, oh. Flattery will always work. So there I am.
All right. Well, I'm excited. I felt like I had more time this week to spend on a couple of the papers I added, which has not been true the last couple episodes. So everyone stay tuned. So Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we? And I am, for one of the rare times, opening up our viral section. Please be sure to listen to This Week in Virology and Daniel's clinical updates. This first paper I pulled is right up my alley. And so it's from Transplant Infectious Diseases, entitled Incidence and Timing of Epstein-Barr Virus, I'm going to say EBV, Whole Blood DNAemia, and EBV Mismatch Adult and Pediatric Solid Organ Transplant Recipients. And so, as many people probably know, EBV viral load monitoring is recommended post-transplant for our mismatch, so donor positive, recipient negative, solid organ transplant recipients. But how we should do that, at what frequency, all of that is really just not clear. And so this was a retrospective cohort study. It was looking at the incidence and timing of whole blood EBV DNAemia in, as the title mentioned, EBV mismatch adult and pediatric solid organ transplant recipients who had EBV viral load monitoring as part of a preemptive approach to PTLD. So at this center, the University of Alberta and Stollery Children's Hospital, they monitored for the first year post-transplant, along with interventions like reduction in immunosuppression at the physician or transplant team's discretion. They checked weekly viral loads from weeks 4 to 20 and then spaced out to monthly for months 6 to 12. I will also note that they give ganciclovir or valganciclovir specifically as antiviral prophylaxis for patients who are EBV mismatch for 14 weeks post-transplant. And then if a patient is a candidate for it, that could be extended in the setting of CMV prevention. And so they analyzed 257 of these mismatched recipients. Most of these were liver and kidneys. Oh, actually, I take that back. There were quite a lot of hearts. So 93 livers, 75 hearts, 64 kidneys, 25 lungs. They found that about half, so 126 of 257, developed DNAemia in the first year post-transplant at a median of 83 days or about 3 months post-transplant. The incidence varied by organ. It was highest in liver at 62%, lower in heart at 28%. That incidence of the viremia or DNAemia happening less in the heart compared to liver and kidney patients in the study was not sort of further confirmed when they did multivariable analysis. They did find another interesting pattern that when seropositive donors inconsistently transmitted EBV to multiple recipients, the non-infected recipient was usually a heart, and that has been observed actually in CMV. And then there was a lower risk of EBV in lung in this study. Sorry, I should say lung transplants. But the lung transplant group also were the patients that had the least sort of adherence with the monitoring checks. So the lower risk was actually lost when they sort of further analyzed it if they restricted it to just people who had at least half of the monitoring checks that would normally have been done. And so why do we care? We're always wondering about PTLD. So PTLD, or post-transplant lymphoproliferative disease, was diagnosed in 38 out of 257, or 15% of these recipients. And so I think one of the big take-homes to note from the study that hasn't really been reported previously is that there was a very low risk of EBV anemia in recipients less than 6 months of age, regardless of the donor's age or the presence or absence of maternal EBV antibody. And this lower risk did seem to also be there for recipients that were under a year who got organs from seropositive donors who were less than 12 months. I think the mechanism of this isn't totally clear. There is some data suggesting that maybe infants are protected from natural EBV infection in the first 6 months of life. Maybe there's a component of passive maternal EBV antibody, but I think it's probably a mixture of things, because it's not clear that if, mom had an EBV antibody, if that would totally protect against an organ sort of donor-derived EBV infection if it's bypassing our normal mucosal protection barriers. And then the last thing is sort of what they suggest. So they propose monitoring for EBV could be focused to increase cost effectiveness and decrease the burden of monitoring by, 1, delaying initiation of the monitoring until about a month or so post-transplant, focusing on months 2 to 6 post-transplant for monitoring to really maximize detection, and that maybe less frequent monitoring is probably safe in those young recipients. So kids that are less than 6 months, or children that are recipients between 6 to 12 months old who also had a donor who was less than 12 months old. So this is quite large, actually. I did my fellowship project in EBV, so I've looked at this data before, and this is a big study for this type of question, and it's really interesting. Their surveillance monitoring, they had like 92% adherence, which is really cool. It's for us to get, better insight into the timing of when and how EBV anemia is happening. So I also included some of the graphs. I realize I skipped over, but folks can check those out in the paper, of course. All right. And then I pulled another interesting paper. This one is from Pediatrics. Infant Respiratory Syncytial Virus Immunization Coverage and the Vaccine Safety Data Link, 2023 to 2024. The authors here look to assess the proportion of infants immunized against RSV through antenatal RSV vaccination. So I always struggle on the trade name, Abrysvo, given during pregnancy, or if the baby receives nirsevimab, the monoclonal antibody given to children after birth. And so they use data from the 10 Vaccine Safety Data Link health systems. I put a little map picture to show where those are. They're kind of scattered throughout the US. And so the recommendations right now are that you can get one of these products, one or the other, unless the baby was born within 14 days of the mom getting the antenatal vaccine. So close to 37,000 eligible infants were included from a little under 44,000 pregnancies. Overall, 72% of infants were immunized against RSV. That rate was highest among infants born to non-Hispanic Asian mothers at 84%, but there were disparities identified by race with 60% coverage among infants born to non-Hispanic Black or non-Hispanic Middle Eastern or North African mothers. Coverage was 59 to 78% when they broke it down by birth month, with nirsevimab more commonly administered to the infants born earlier in the season. So this coverage is pretty high. That's exciting. This is an early assessment. This is basically the first respiratory season following licensure and recommendation of RSV, infant RSV coverage. But, it's very useful to also see that they revealed some important racial and ethnic disparities in coverage. And so, we're at this major moment of being able to prevent RSV, which is crazy as a pediatrician. So I think, we're acknowledging that we have these awesome tools. We just got to figure out how to roll them out and implement them and make sure that we communicate them and are committed to equity and getting it to everyone who needs it. So I thought this one was very, very cool, very exciting.
Okay. Well, while you were getting me excited, I pasted in an extra. So I just added the article, Impact of Nirsevimab on RSV and non-RSV Severe Respiratory Infections in Hospitalized Infants, published in Influenza. So, if we do a great job, what happens? Well, the monoclonal antibody Nirsevimab, Beyfortus, became available to prevent RSV in infants in Spain in October of 2023. And rates of respiratory infection-related hospital admissions dropped 63%, plummeted. ICU admissions plummeted 75%, and admissions for RSV fell 78%. And the ones that did get Nirsevimab, that did end up in the hospital, shorter stays, milder disease, less need for high-flow oxygen.
It's so incredible. It
works.
Amazing. Yeah, it's so great.
Amazing stuff. We just got to make sure everyone gets access to this, right? So big educational push there. All right. The article, Time to Antiviral Treatment in Mild to Moderate COVID-19 in the Emergency Department, Influence of Prescribing Physician and Effect on Outcomes, was published in the journal Internal and Emergency Medicine. So here, these investigators conducted a nationwide multi-center retrospective cohort study in 16 Spanish EDs. They collected data from patients with mild to moderate COVID-19 who presented to an ED, received antiviral treatment, and were at risk of disease progression due to advanced age, comorbidities, or immunosuppression. So I just want to point out, right, and we keep sort of hammering this in, you don't just give everyone antivirals. There's certain criteria. And they found that longer time to treatment, they've got these wonderful two-letter acronyms, TT, time to treat, was associated with worse outcomes. Prescription by an emergency physician was associated with a reduction both in time to treat, of course, and in hospital time, HT. Now, remdesivir or Veklury was the most commonly prescribed antiviral, 50.6%. Followed by Paxlovid, 43.3%, Sotrovimab, 3.7%, Molnupiravir, 1.9%, and there were some combinations as well. Each day of delayed antiviral receipt raised the risk of hospitalization or death 17.9%. Prescription by an ED physician was linked to shorter hospital time. Adjusted mean reduction was about 8.45. Earlier ED administration of antivirals for mild to moderate COVID-19 in vulnerable patients is associated with better clinical outcomes. And prescription by an emergency physician, the ED, shorter hospitalizations and shorter time to treat. And they got this really nice antiviral treatment graphical abstract. I don't know, why do they have the people with the little canes, right? Is that reminding us this isn't just for everybody, it's for the vulnerable or something there?
I realize there's also a little scale, isn't there? Is that the scale on the fourth
It
one?
looks like a scale. I'm not even sure what that is, right? But it's got the little feet on there. Maybe they're trying to remind you,
because
the
it's
virus, the old person, the chubby person with a little too high a BMI.
Oh, that's definitely what got it. Yeah, that makes sense.
You're going with trying to remind you to think about BMI and age and some of the other things there. So,
and then I think I'm rounding out our viral section. I actually threw this in just before we started recording. There was a update to the PEP recommendations for HIV. So an MMWR, antiretroviral post-exposure prophylaxis after sexual, injection, drug use, or other non-occupational exposure to HIV, CDC recommendations, United States 2025. So I'm just letting people know there's a quick update. I can summarize this quickly as far as what's updated from the 2016 document. They now have preferred regimens for HIV post-exposure prophylaxis in adults and adolescents is now Biktarvy, Biktarvy, bictegravir, emtricitabine, tenofovir, alafenamide, or dolutegravir plus TAF or TDF plus emtricitabine or lamivudine. The other major points are what we have already known, trying to give this ASAP after exposure within 72 hours. So I think this is great news. Folks no longer have to sort out, like, does the ED or wherever they're getting it have raltegravir versus dolutegravir / can't we just use Biktarvy? So now you can feel good and have your recommendations to back you up.
Isn't everybody on Biktarvy, Sarah?
I know. I was talking to someone about regimens the other day, and because we were trying to work on puzzles for some educational games, and we're like, oh, how are we going to make something when the answer seems to always be Biktarvy?
Yeah, I'm going to do a talk tomorrow morning for like the team, and it could be the long, complicated, or just everyone needs to be on Biktarvy.
Yeah.
All right, let's move us into bacterial. Be sure to listen to This Week in Microbiology, and also probably Microbial Matters, right? David Renata was reminding us. So I was rather excited about this article, Validation and Clinical Implementation of Cerebrospinal Fluid C-reactive protein for the Diagnosis of Bacterial Meningitis, a prospective diagnostic accuracy study published in The Lancet Regional Health. So can we use CRP to diagnose bacterial meningitis? So validated CRP measurements in CSF for the diagnosis of bacterial meningitis in a Danish cohort of patients with acute CNS infections and a Dutch cohort of pediatric patients suspected of a CNS infection. They evaluated the implementation of CRP measurements in CSF in clinical practice after this validation. So in this study, here we go, CRP and CSF, I like that, CRP and CSF was measured in 103 adult patients from Denmark, which included 33% bacterial meningitis patients. The AUC was 0.92 with a predefined cutoff of 0.3 milligrams per liter. And maybe in things that make more sense to people, the sensitivity was 85%. The specificity was 96%. In 77 Dutch children, 22% of patients with bacterial meningitis. The area under the curve was 0.95. Sensitivity was 94%. Specificity 98%. So from June 2024 to November 2024, they included 80 patients in their clinical implementation cohort, of which 19% were diagnosed with bacterial meningitis. The AUC for CRP and CSF, I like that, was 0.99. Sensitivity 100%, specificity 94%. Across all cohorts, the combination of CSF leukocytes, CSF CRP, improved diagnostic accuracy compared to CSF leukocytes alone. And then we've got some nice graphs. We can actually see like all the data points, and we can see bacterial meningitis versus a viral CNS infection.
I pulled something from OFID, Bridging to Transplant, TDM, Therapeutic Drug Monitoring, Guided Outpatient Dopavansin Therapy in Chronic Granulomous Disease with Deep-Seated Inoperable Abscesses over 11 months. This was in that novel case category. I think that's what they call them. So I really like talking about immunodeficiencies, and I feel like it's been very on my mind because I presented on some earlier this week. And, I always like to remind people about CGD, and I have actually a slide that has the typical CGD organisms, or like the top 5. So I figured, why not do it on Puscast? So Staph aureus, Burkholderia, Serratia, nocardia, and aspergillus. And, the most common infection causing mortality is fungal infection. So separately, getting back to the paper, this was a report of a 23-year-old who has X-linked chronic granulomous disease, who had persistent inguinal abscesses and later had lots of complications with fistulous tracts and ultimately sort of tracts of the sacrum and bony disease. So cultures had, I believe, coag-negative staph and Acinetobacter loafi. I realize I've never said that out loud. I've only read it. So they didn't have a great surgical option because of the extent of disease. And they tried this regimen of long-term ciprofloxacin and dalbavancin in an effort to try to avoid also having a long-term central venous line. They ended up doing dalbavancin for about 48 weeks of therapy, so almost a year, as they were sort of working towards bone marrow transplant. And, they shared that they were using these serum drug levels to adjust the dosage along the way. And they have a chart that I sort of snipped for us to look at. And I think, this is obviously a very specific, unusual case, but I haven't used dalbavancin monitoring before, and it caught my eye. And so you can see that they initially gave the patient 1,500, 1,000 for a couple doses, and then we're using a 500 milligram dose. So, just thought I would pull it up because I like CGD and had read it and thought it was interesting.
All right. Now, I love articles like this one. Nitrites for urinary tract infection. Time to say goodbye? Question. Published in JAMA Internal Medicine. So a little background is provided. Asymptomatic bacteria was initially recognized in the 1950s, but management was rarely discussed in the literature before a 2005 Infectious Diseases Society of America clinical practice guideline and a 2019 update. Asymptomatic bacteria occurs in both adults and children and is defined as the presence of, I'm going to put my glasses on for this, 10 to the 8th CFU per liter or greater in a voided urine specimen without signs or symptoms attributable to UTI. Now, the article continues, testing for urinary nitrites can be traced back to the early 1900s due to discoveries made by Robert Koch and was first associated with UTI in 1914. What a wonderful history we've got here. Now, today, the urinary nitrite test continues to be a standard component of the macroscopic dipstick portion of the urinalysis assay. Urine normally contains nitrates as waste products of dietary protein, and a positive nitrate dipstick indicated by a color change indicates the presence of nitrate-reducing bacteria in the urine. So bacteria that possess the nitrate reductase enzyme include, this is like one of the ones you always like pimp people in rounds, right? What are those bugs that have the ability to reduce, reduct the nitrate? E. coli, Klebsiella, but it's absent in Acinetobacter and Enterococcus, right? So does that mean if you've got the positive nitrite, does that mean you don't have to worry about Enterococcus? Interesting. Well, a 2019 meta-analysis reported similar diagnostic performance of nitrates for UTIs in children in this age group. Again, not requiring symptoms for the practical reason that it is rarely possible to ascertain symptoms in young children. Is that true? Is that true, Sarah? You can't ask young children if they have like urinary discomfort?
Sometimes.
I kind of feel like you can. I mean, I had kids. All right.
Yeah, I think, sometimes we just, people should, sometimes they can share.
All right. So a 2024 guidance paper on vesicoureteral reflux also stated that nitrates had a 99% specificity for UTI, but again, there was no requirement for presence of symptoms. So I guess the specificity is for a UTI or asymptomatic bacteria all lumped together. Now, in adults, current guidelines do not comment on the utility of urinary nitrates for the diagnosis of UTI. The most robust examination of the literature informed the use of nitrates in adults comes from a meta-analysis in 2004. Now, Now, although the authors concluded that nitrates had a high positive predictive value and specific UTI, the definition of UTI, again, included both symptomatic and asymptomatic bacteria. Do you see where this is going? All right. So what to conclude? Now, I like the reminder that there can be false negative results with pathogens that have the enzyme, since it's speculated that organisms must remain in the bladder for approximately 4 hours to produce detectable nitrites, right? So you got that patient who's got urinary frequency, they're peeing every 2 hours. Okay, you're not going to get those nitrates. Bacteria that possess the nitrate reduction enzyme include, as we mentioned, E. coli, Klebsiella. However, not seeing that in Acinetobacter enterococcus. So I suggest we just use caution, and maybe we should put the warning, the sort of a warning to use the nitrates with this knowledge.
I like that. Yeah. I actually recently feel like I haven't had as many people say, oh, the nitrite was positive, but it's probably because there was some mild pyuria for someone to focus on instead.
Well, it's, one of the things I've started to notice people saying, and maybe you've seen this and can comment, is they say, oh, and the UA was positive. And I'm like, what does that mean? It was positive. Positive meaning it was like above some trigger threshold that's going to get a urine culture, or there were like white cells above a number, or what does positive mean? Because they would say patient came in with positive UA, and it just kills me because I want to know, I want to know the number of white cells. I want to know Luke
It's like one ring above when people say the UA is dirty. Which I
Yeah.
also don't really like.
Yeah, what does that mean?
Yeah. Don't love that. All right. And so I will take us into our fungal section. We are, of course, continuing to plug Last of Us Season 2. I am not caught up on the most recent episode. I walked into a patient's room today and he was watching. I had to look away to get no spoilers. So even though I know the story from the game.
You had to look away to the TV, away from the patient. What happened?
Yeah. So I pulled a paper. This was in OFID. High mortality and associated risk factors in kidney transplant recipients with cryptococcosis, a nationwide cohort study over a decade using USRDS data. So this retrospective cohort used data from, the acronym was U.S. Renal Data System, to look at hospitalizations and outcomes for crypto among kidney transplant recipients in the U.S. for the decade starting in 2006. So this database apparently integrates some of the UNOS data and some Medicare's claims data. They found 1,265 kidney transplant recipients who were hospitalized for cryptococcus from almost 2 million hospitalizations in that data set. Describing these patients, they were about 60 years old, 2/3 of them were male. From a geographic standpoint, there were more patients from sort of the south part of the U.S., so that was 48%. The median time to index hospitalization was 30 months. And then just other things I pulled out, there was about half who had diabetes, 3% who had cirrhosis. They found that about 70% underwent an LP during their hospital course, and 51% had a diagnosis of cryptococcal meningitis. Other things that we often look at is about 14% experienced rejection and 44% required some time in the ICU. They found that the overall 6-month mortality rate was 22%. And some of the factors associated with increased 6-month mortality in their multivariable logistic regression included cirrhosis, ICU admission, need for pre-transplant dialysis, lack of tacrolimus use at follow-up, patients over 60 years old, over 2 years from transplant, and prior hospitalization for complications. So, I think the things to take away is the early mortality was quite high in these patients who were hospitalized for cryptococcus. And I thought the other kind of good reminder is that cirrhosis is a really important and independent risk factor for mortality. I teach learners about how cirrhosis in and of itself, like excluding the conversation about transplant, is a risk factor of getting cryptococcus. So something to really be careful of if you have someone who has cirrhosis and or other complications, other comorbidities or transplant. And yeah. Oh, that's our only fungal one. I could have sworn I put another one in here. Well, I'll hand it over to you for parasitic.
All right. So be sure to listen to This Week in Parasitism. I'm going to do 3 papers here, and then I think Sarah's going to wrap us up with our miscellaneous section. But the article, Performance of a Novel P. falciparum Rapid Diagnostic Test in Areas of Widespread HRP 2/3 Gene Deletion, was published in CID. So these rapid tests, these RDTs, have really improved malaria diagnosis. However, we've had the emergence of this HRP 2/3 gene deletion, really threatening the reliability of these tests. Now, this study evaluated the diagnostic performance of a novel RDT detecting both HRP2 and P(f), so Plasmodium falciparum LDH, in a single test line. Cross-sectional study was conducted at 2 health centers in Ethiopia, recruiting 1,004 study participants. Blood samples were tested using the novel and comparator RDTs, using microscopy and nested PCR as the reference standards. P. falciparum HRP2 and HRP3 genotyping and HRP2 and P(f) LDH antigen quantification were also conducted, and they found in the study setting characterized by 80% of P. falciparum infections showing HRP2 or HRP3 deletion, the novel RDT showed a sensitivity of 77% and a specificity of 96%. So good stuff there. The article, Prevalence of Anopheles stevensii in Horn of Africa, a systematic review and meta-analysis, was published in BMC Infectious Disease. A total of 14 studies were included in this systematic review and meta-analysis. They piled them high. From this meta-analysis, the pooled prevalence of Anopheles stevensii was 41.26%. The subgroup analysis based on your publication showed that the pooled prevalence of Anopheles stevensii in studies conducted in 2014, 2018, 99%, while it was 36.82% if you look at studies 2019 to 24. Now, on the other hand, country-based analysis showed all these different prevalences in different regions. Now, why is this important? Why are we following Anopheles stevensii? Anopheles stevensii was formerly thought to be an Asian malaria vector. It's been a primary cause of disease spread in urban areas of India, Pakistan, Iran, and the Arabian Peninsula. Now, the presence of Anopheles stevensii in Africa has led to distinct transmission patterns compared to Asia, primarily due to its adaptation to urban environments. So we're now seeing outbreaks in cities where malaria was previously uncommon. And we have the open access article, Raising Awareness of Demodex Mites, a Neglected Cause of Skin Disease, published in the journal Infection. So we will share this article. Also, raising the awareness for our listeners. Nice graphical abstract. It's a little weird, right? Like, doesn't it seem like it's stretched out, the graphical abstract, right?
Yeah.
Seem like, and it is, it's sort of stretched out, but it's a nice graphical abstract. And they go into the challenges in diagnosing the condition, also a nice discussion on some evidence-based treatments, right? So they've talk about oral medications, tetracycline, doxycycline, ivermectin, permethrin, metronidazole. They even talk about some topical medications, again, topical ivermectin, but they also talk about topical metronidazole and a nice section on alternative and supportive measures, like all these medicinal oils like tea tree oil, camphor oil, bergamot oil, peppermint oil, black seed oil, castor oil, sulfur ointment, yellow and white mercury ointment. So a bunch of different things to do for what unfortunately is really a neglected and I would say underdiagnosed condition.
And I think all of the final ones in our miscellaneous section are mine. The first thing that I didn't know quite where to fit it in, so I put it here, is folks may have seen the article Scientific Integrity Under Threat, the role of IDSA, PIDS, SHE, journals in an evolving political landscape. So this was sort of cross-published through the various journals, most of which we most frequently talk about on this podcast. So the various editors-in-chiefs, provide a statement on scientific censorship and consequences, impact of scientific publishing and knowledge dissemination, which really relies on transparency and peer review and being able to openly exchange ideas, and the threats to global health equity and collaboration. And so, they're basically sharing their commitment to have open and inclusive scientific discourse. And they said they invite our colleagues to join us in this effort, ensuring that the pursuit of knowledge remains driven by facts and not by ideology. So the next thing that I pulled is actually it's not technically ID, but it's relevant. Journal of General Internal Medicine, Reasoning on Rounds, Volume 2, a framework for teaching management reasoning in the inpatient setting. And I just wanted to highlight this because there's a couple wonderful ID docs on it. But they talk a little bit about management reasoning and how difficult it is for us to share our thinking process and how we integrate, clinical factors, clinical data and other factors. This actually was published a while back, but it's in like a current release of the paper, so I'm including it. And they talk, a little bit if anyone has read about these concepts, how we think of management and diagnostic reasoning is somewhat different. Whereas in diagnostic reasoning, we're trying to what they called a classification test. We're trying to get a diagnosis based on what data we have, what hypotheses we've generated. Whereas management reasoning is more of a prioritization exercise. We're adapting multiple possible plans. We're incorporating what resources do we have available? What do our patients prefer? And so even though these can kind of overlap, they often require different frameworks for us to explicitly share our thought process with our learners. So they give some background on the theories and some of the sort of frameworks that might be helpful for applying this on inpatient rounds. And some of those examples are management scripts, what they call a management pause when you have moments of uncertainty, among some other things. So I encourage people to read that. And I actually don't know if we pulled these papers specifically, but in CID, there's now this clinical dilemmas in infectious diseases where they're walking through ID cases and the authors and basically like a discussant share how they're thinking about the case and in the context of kind of diagnostic management reasoning. So if people haven't seen those articles, you can pair all of these together. And then the last miscellaneous one I have is in JPIDS, Billing for and Documentation of Provider-to-Provider Interprofessional Consults in Infectious Diseases. I will shout out the first author was one of my co-fellows. But the authors here share their development and implementation of a pilot process to support ID docs in a way to document and bill for these 9944 something codes for provider-to-provider consultation phone calls. And so that's where this term, they said the interprofessional consult, and they give their note template that they built to have all the elements that we need for this sort of IPC, provider-to-provider documentation, like the verbal discussion. So basically converting curbsides. And so they got some reimbursement data back, at least for some of the pilot, based on about 75 of these notes that were written by 11 attendings and 3 MPs. The mixture of these curbsides or interprofessional consults was about 47% outpatient, 40% inpatient, and 13% from the ED. They billed for a median of 25 minutes. The most frequent question was interpretation of some sort of positive result, 12%, and followed closely by antibiotic selection for a positive urine culture, 11%. From the 56 of these consults that had completed a revenue cycle, 50% were reimbursed by insurance. The median payment was about $40 from Medicaid to about $130 for commercial insurance. So I thought this was really neat. We're always talking about how can we do this and how people should approach curbside. So it was really nice to see someone share what they've tried to do. And I actually sent it out to some of the folks that I work with about how we should do this. But yeah, I don't know, Daniel, have you used these codes before or done anything similar?
Yeah, I've never used these codes.
Yeah.
But I am intrigued, right? I mean, this is certainly, like, we always talk about all the unpaid work that ID docs do, and my dad always says, but Daniel, you call it work. If you find something you love, you'll never work another day in your life. I'm always like, yeah, Dad. But anyway, it is work. So it's nice to get paid for it. It'd be nice to, it'd be nice to look into this, So when you're sitting there on the phone for half an hour doing one of these interprofessional consults, because we spend time. And I guess it looks here like you've got to somehow not only have that verbal discussion, but also document it as well.
Yeah. Amazing. All right. Well,
and we are silly, Sarah. Look, we're all excited about an extra $40. Like, talk to our surgeons who will just laugh at us.
But it's 40 times the many consults curbsides that we get.
All right, we'll go with that. Yeah.
Well, that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, at microbe.tv/Puscast. Grab it with your favorite podcatcher. Watch it on YouTube. And if you do that, make sure to subscribe, like us, ring the bell, and leave positive comments because I am a little sensitive. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute or parasiteswithoutborders.com and click on the donate button.
I'm Sarah Dong. You can find me at Sarah Wynn Dong or Febrile Podcast on Blue Sky or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts This Week in Parasitism and This Week in Virology Clinical Updates.
Thanks for listening. We'll be back in 2 weeks. Another podcast is infectious.